these are the biggest diabetic hospitals in Southeast Asia. My center, you know, and these are the recent with the new director of the Butsov, and you can see here young new director and professor. You can know the ILIZAROV method has been awarded nowadays more than 100 countries of the world since 1981. And now if you look at this definition, I thought myself that what will be the definition of the non-union: arrest of the bony fracture repair process with the formation of fibrous or cartilaginous tissue in between the main fragments, and the fracture has remained ununited for 6 to 9 months due to biological or mechanical failure judged by clinical and radiological evidence. Now, what are the main issues? You all know all these things: bone loss, soft tissue loss, infection, gap non-union, scarring, deformity, shortening, bone and muscle atrophy, diffuse osteopenia, psychological problems. And if you talk about the infected non-union, there are two schools of management. One is conventional method and another is the ILIZAROV management. So, dear friends, today the orthopedic surgeons that we are treating all these kinds of conventional and ILIZAROV methods. If you think about the conventional method, modalities take a long time to heal, need multiple operations, and you can get the complications as well as the failures. Often it is very frustrating to the surgeon as well as to the patient. A simultaneous treatment by ILIZAROV technique, radical debridement, bone transport, acute shortening, and then lengthening. And what are the strategies? Two strategies treatment. If you think about the stage 1, infection eliminations, radical debridement of necrotic and infected tissues, and of course you are applying sometimes the antibiotic beads and the cements. And in stage 2, reconstruction of the bone and soft tissue, and sometimes you need to go for flaps, autogenous bone graft, cancellous, cortical and vascularized. Now, if you think about the infected non-union classification, you'll see Rosen et al. In EU manual have divided this into two broad categories: infected non-draining non-union, which is further divided into quiescent and active. Quiescent, again, dry non-draining, all this at least 3 months, and active non-draining but with abscess and the fever, and infected draining non-union. A new method classification of the infected non-union is proposed depending on the severity of the infection, the opposition of fragments, and the presence or absence of the deformity. Now, classification that I told you indicates guidelines treating the infected non-unions. There are 3 types. Type 1, this is very simple, with mild infection. Type 2, fragments in apposition with moderate to severe infection with moderate to severe. And type 3, which is difficult for the orthopedic surgeons, and we are dealing all the time with type 3 severe infection with gap, deformity, shortening and everything. Now, non-unions are, that I told you, radical and thorough debridement, compression of non-union by ILIZAROV fixation with lengthening or bone transport, conversion to internal or hybrid fixation in less severe infection, and augmentation of healing by bone grafting. This one, last one that I told you, I have never done in my life till today. And even some of the orthopedic surgeons, they are doing. These are the following factors important in the management of non-unions: the radical debridement, first and perhaps the most important part of the management. And how to do that, you know, these are the things sequentially. You should have to remove loose implants and resecting centimeter by centimeter, and you will get the punctate bleeding that we call the paprika sign, and removal of the nephrotic tissues. If you have intermediate canal, you should rim that one for removing the debris and excision of the scarred and infected soft tissues. and repeated debridement. Sometimes it needs 2 or 3 days under general anesthesia. Fracture stability is very important at the time of radical debridement. Ilizarov fixators are ideal because internal fixation that we are doing for intermediate nailing or plates can cause further devascularization, which will lead to aggravation of infection. Soft tissue coverage, sometimes you do that, and preferably plastic surgical procedures to cover the bone should be done after 8 to 10 days when wound is covered with healthy granulation tissue. Bone grafting that I told you, implant removal. Now, regarding the treatment of infected non-union type 1, if you look at this, in our experience, functional cast has given excellent results. Patient is forced to work as much as he can. If there is a loose implant, plate or nail, it should be removed. The cast is changed after 4 to 6 weeks. X-ray are taken if necessary. Cast can be reapplied, and second alternative is to apply external fixator immediately. And type 2, see, non-union is treated by Ilizarov method because it simultaneously addresses all the problems of type 2. And type 3, this is best treated by Ilizarov technique because here you will get shortening, deformities, gap, infection, everything which can be treated fantastically by Ilizarov technique. Again, if you think about the type 3, it is divided into 3 groups, 3A, 3B and 3C. A, there is no gap but deformity or shortening. If you wish, you can treat this by Ilizarov or other technique. And type 3B, complete defect of all circumference of the cortex with large wound. This is best treated by Ilizarov. And incomplete defect with partial circumference also you can treat by Ilizarov. Now, what are the problems of INU, infected non-unions, that I told you earlier, and I want to add this one. See here, the sinuses, osteomyelitis, bone and soft tissue loss. You will get the fibrosis, osteopenia, skin problems, adjacent joint stiffness, complex deformities, limb length inequality, and multiple resistant polybacterial infections. These are the problems of the INU. Now, based on this, a few basic principles we must know. Sometimes you need to go for biopsy culture. All necrotic and non-bleeding bone must undergo debridement. A high-speed bar is used to debride the bone, and the continuous cooling irrigation is applied to the bars. And tibial cortex experiences very little bleeding. We must look for the paprika sign that I told you earlier. Now, which one is very important? Ilizarov effect and law of tension stress. You see, dear friends, before Ilizarov, there was the invention of rings, but the biological parameters and law of the tension stress, which is described by academician Ilizarov, slow and steady traction on a living tissue creates a stress which is metabolically activated in both the biosynthetic and proliferative pathways depending upon the vascularity and the functional use. Professor Ilizarov in 1983 showed that blood supply after applying the Ilizarov will increase at 330%, which was research work by applying the apparatus in the dogs. And treated infected non-union is a challenging problem for most of the orthopedic surgeons. And what I should tell you, Ilizarov is the best fantastic tool which can treat, which can be managed by this fantastic tool. Now, corticotomy, you know, common mistakes during corticotomy. Corticotomy is very important. This is the part of the Ilizarov surgery. Too large skin incision, poor choice of corticotomy level, uses of oversized osteotope, destructive hammering of the cortex, direct cutting of the bone marrow canal, injury to nearby vessels and nerves, performance of twisting corticotomy maneuver before complete cutting of medial or lateral cortex, and sometimes you can do the incomplete corticotomy and traumatic corticotomy. Sometimes if some surgeon is not expert, then he may do this kind of traumatic corticotomy. Now, dear friends, I'd like to share some cases, difficult cases with you. Before putting the Ilizarov apparatus, you must know the safe corridors. Within a short time, it is not possible to explain you everything all the time. If you are expert with the Ilizarov technique and the apparatus and the methodology, you will be able to apply the Ilizarov in a proper way. Look at this in the humerus. You must know this is, you'll see infection, loosening. Then what I have done, applying the apparatus, only the wires, playing with the wires. Look at the right side, radiography view with Ilizarov apparatus, and this is during treatment, after removal of the apparatus. Now you can see after only 4 months. So this is, you can see radiography view, final follow-up. Again, the safe corridor. This is very important also. Look at this infection, the right side, see. These are the cases that if you know the principles and the philosophy of the Ilizarov, you can have a very good result and outcome with this kind of, which was applied before plate and screws. You just remove. I put the guide wire inside, only the K wire is smooth, and see the only playing with the wires and the Oli wires. And this is after removal, after treatment. See again, Gastilo 3A, he was treated elsewhere, infected non-union long bones. This is the ulna. This is again wide incision. You must know the safe corridor. He at the same time at the on non-union also femur also. Now you see 4 ring constructs with the wires. Then I have done the corticotomy and gradual lengthening. Now you can see here from this after 1 year follow-up, it was a big long gap. So again see non-union, which is treated by the rash nail, lady, forearm. Now you can see here again playing with the wires and the Oli wires and the smooth wires. So this is the final view from this situation to that situation. Deformity and the non-union with rash nail. You can see here. Say again, in the proximal femur, you must know all these things. Whenever you are applying the Ilizarov in the femur, lots of orthopedic surgeons, they are telling all the time, this is a cumbersome. I must tell you, cumbersome for the, not for the surgeon, it's cumbersome for the patient or surgeon. Now see, this young gentleman, 35 years, he was treated with gentamicin bits and at the same time with interlocking nails. So infection was, bits did not help. Then he came to my place. I have removed everything. Only in the proximal part, I put the shants, and you can see here in the middle and distal part, this is with the wires, smooth wires and the Oli wires. This is after 7 months, and this is after 5 months follow-up. Look at this from this situation to that situation. So these are the case. Again, you can see which was treated by plates and screws, bulky, lady. Look at the thigh, very difficult, bone quality was not good. There was a discharging sinus, and then after removal, clinical appearance of the patient, this is after 5 months follow-up. Now we can see this is after 8 months from this situation to that situation. If the patient is obese, sometimes it is very difficult to treat these kind of patients. Look at this. I have a bitter experience of this gentleman from Somalia, 130 kg. He was treated 18 times in different countries. In Somalia and Uganda, and then in Singapore, in Germany. Then he came to my place with 130 kg. Look at this thigh. He's a teacher. He's a teacher. Then during treatment with the Somalian, look at this. If you look at the apparatus, you'll see that it will look like a very clumsy, But look at this, what I have done. So, these are the shunts, and I put multiple console wires. These are the console wires, and gradually, console means from one cortex to another cortex, don't pierce the second cortex. And gradually you just pull these wires. As a result, you are increasing circulation in the whole limb. And what happened you can see. And after 6 months follow-up, this is before, and this is, you can see, after 6 months follow-up. 6 months follow-up. So 18 times he underwent surgery in different places. And this is the man who is the teacher of the university, sent me this video. He's calling me as a hello. So this case, now dear friends, I'd like to share this case with infection and osteomyelitis. See the discharging sinus of a 3-year-old boy. I have done nothing. What I have done? Just I put the apparatus. After 2 months follow-up, you see, with the wires. This is after 3 months follow-up. And this is, you can see here, first step surgery, radiographic view with CAFO. This is after 5 months follow-up. Look at this. I told the patient, after applying the apparatus, you just bear the load and walk, load and motion. And this is after 11 years, you can see from this situation, pathological fracture, discharging sinus, and this is after 11 years. Then again, patient came to me for second step surgery. I did this lengthening in the tibia and the femur. Look at this. And in the tibia, always I put the wires, not any pins. In the proximal femur pins, now full correction, 12.5 centimeter LLD. Then you can see from this situation to that situation, this is after 12 years. So dear friends, so Ilizarov, in this kind of patient, there is pathological fracture with osteomyelitis in the long bones, you don't need to open, and you can treat nicely with this kind of Ilizarov apparatus. The more difficult the case, more is the Ilizarov. Ilizarov keep you safe, plan it to realign, and preoperative planning. See, the power of planning is very important. This is the case. Young boy, 17 years, situation in a baby taxi, you can see here. This is the bone. After 7 days, he came to my place and told me, doctor, this is my bone. Can you put this one? See? And in our another place, advised him to go for imputation from here, 26 centimeter. Look at this, 27 centimeters, sorry. And then I have just seen the vessels are okay. Fortunately, the vessels are okay here. And he had the same time in the ipsilateral tibia also, ankle, distally injured. Then I have lengthened, see, bifocal. From here, lengthening fast, and here. These are the cases, challenging cases. Very big gap, 17 years old boy, and then 7 months follow-up. Now you can see, dear friends, how he's walking. So this is the case. Now you can see the after 10 months treatment from very big, centimeter big. This was, there is a publication, Destruction Osteogenesis, Technique for Infected Gap Non-Union of the Femur in American Journal. Now again, safe corridor. Every steps when you go, it is very easy in case of tibia. Look at these, the concerns, what, dribbling pass. This is the case, situation. In our area, in our regions, in India, in Bangladesh, in Pakistan, and this Sri Lanka, or even then in Myanmar, this kind, you are getting lots of cases like this. Dear friends, look at this. Dribbling pass. Then these are the cases that can be best treated by Ilizarov technique. And with Ilizarov, after 4 months follow-up, 5 months, and you can see here from this situation to that situations after 1 year. Look at this, and this is after 2 years follow-up. Look at this, again tibia, safe corridor, you must know, no bones. See, treated elsewhere, came to my place, and I am playing all the time with weights. I love to do that, and before treatment after 3 months, and this is another case treated elsewhere with devastating injury with uniaxial fixator, and again you can do something whenever you have Ilizarov in your apparatus and you know the principles, and if you follow the philosophy and principles. Again, this kind of discharging sinus with uniaxial fixator treated elsewhere, all infected cases. See, and this is after the treatment. So, dear friends, again you can see that this is one interesting case. I have put you can see here, these are all the console weights to control the infection. Only 2 rings, and you can you can control the infection after doing this kind of surgery. And another one, you see, very big gap on the infection, 28-year-old. You can do of course, go for the amputation, and for prosthetic limb you can apply, but the patients cannot. Patient's relatives and patient is not willing to do all the time. Then what we have done, this is, you know, the tibialization, and you look at this, the segmental fracture of the fibula, you can connect segmental fracture of the fibula, and then you can transport that one by doing the tibialization. From that situation, from this situation, look at this, and this is just after the removal of the apparatus with plaster. Now this situation after only 4 months it took, 4 months. Also this was published in American Journal. And the biological and mechanical method, this is very important, minimally invasive, you know all these things, no need of sometimes free or local flap. Demerits, I don't see anything, only the greater large cup. Ilizarov limitless, and postoperative management is sometimes very important. And I have seen, and we are seeing all the time, the young surgeons, they are applying the apparatus, and they don't follow up the patient. Every day, whenever you apply the Ilizarov, you must follow the stability of the apparatus. So complications, every operations have got the complications, and these complications which you find in Ilizarov, you can easily solve by doing meticulous, intelligent follow-up. And a well-planned step-by-step Ilizarov techniques to cover infected non-union is an excellent method in challenging cases. And you can get the excellent results. Dear friends, the limb deformities, other things, LLD, bony and joint deformities, soft tissue contractures, bone loss, delayed non-unions, infections, transverse distraction, and escaped limbs, you can treat by this fantastic Ilizarov technique. So this is very important for the Ilizarov surgeons. Those who are doing Ilizarov apparatus in the femur, you must have this kind of cut. Otherwise it is difficult. Patient will get pain, and a special cut to recess is important for thigh. And fundamental principles of Ilizarov methodology is load and motion. You must have very good rehabilitation. You must treat the patient and check the apparatus all the time. See, in my center, I always do, whenever you are putting the Ilizarov apparatus in the thigh, you must have exercise protocol so that the patient can get the early recovery. Look at this, what they are doing. You must tell them, no cumbersome. The cumbersome, whenever you don't know how to apply the apparatus in the femur properly. And these are the things that you must follow, dear friends. Now do what they are doing. You must tell them proper application, stability frame, and doing the exercises. These are the very important. Whenever you are applying in the femur, in the humerus, or in the radius and ulna, or in the tibia, you must do the exercises all the time. So these are the patients in my center in every aspect. See all the cases, and the pathways driven law. Challenge is an opportunity. I always tell there are common problems that concern us, the majority in the society at large. So this is, you know, these are my good friends, my teacher, Professor Shirazi, my mentor, and this period, war in Russia, everybody is telling. But we had a very good time with our Indian friends, Manish, Shamsul, and Amar Sani, Kartik, and see our Tashkent Indians, and Omar Barabi is also there, Professor Shirazi, and Anna Mayorovna in Ilizarov Center. These are all stalwarts of the Ilizarov in 16. And my publications, I always love to show this one, dear friends, because see here, I have done reviewer as a 9 PhD theses, DSc thesis 2, and I have now more than 100 publications internationals. So these are the books. Thank you very much. And what I have shown you, this is always, I love to show this one also, evidence, science, and of course the surgical skill of the surgeon. And you can do it, you can do that. So, and finally, dear friend, this is my last one. I always tell this: peace, perfect endeavor around the countries of the earth. So, you can do lot of things by doing Ilizarov technique. Thank you very much for your kind attention and giving me the opportunity to talk in this forum. Thank you very much again.